Hello, my name is Yvonne Chen, a stroke physician and clinical researcher from Edinburgh, United Kingdom. I would like to welcome Professor Raul Nogueira, a neurologist from Emory University in the United States, to talk about the very topical issue of COVID-19 pandemic and its global impact on stroke care. Thank you very much for joining us, Raul. Would you like to tell us about your data and the key findings from your research?
Absolutely. Thank you, Yvonne, for this opportunity to discuss our research on the collateral damage of COVID-19 on stroke care. I think the first thing you need to understand is there are three different mechanisms why COVID can affect stroke patients. I think there has been a fair amount of focus on the direct mechanism of the infection itself, leading to strokes, specifically in the younger patients without vascular risk factors. But I also think you have to acknowledge the problem of the infodemic, the misinformation. Sometimes guidelines are changed without proper data. This actually happened in relation to general anesthesia during the pandemic, and you have had the first few papers pointing out the impact of that. But I think in terms of size, the biggest impact has been this collateral damage, where for whatever reasons, the number of patients that have sought for stroke care has dropped during the pandemic. And we've seen this at several publications at a single center level. And what you try to do, both at US and then in a global scale, was to ask for our collaborators to share data with us, pull this data, to then quantify this effect at a global level.
So you've mentioned a drop in stroke admissions, hospitalizations. Is that something that you've seen across the globe?
Absolutely. Pretty much it happened across the globe. Obviously, we sample 6 different continents, so it's not that you have real global data. It's a sample of that. There is always the risk of some bias when you do this type of analysis, but it was something that you saw pretty much in a global scale. The other interesting factor is when you look at the hospitals, the amount of drop in care, either in stroke admissions or mechanical thrombectomy or intravenous thrombolysis, or even in aneurysm care, it kind of follow the local COVID-19 hospitalization burden, where hospitals that had higher burden of the disease had more significant declines in the amount of stroke care provided.
And that's a very alarming trend indeed. Why do you think that COVID-19 has such a huge impact on stroke care and services?
So I think there are two factors. There is the patient and pre-hospital factor, right? During most in certain locations where like the epicenter of the pandemic occurred, there was hesitation from patients to seek for care. There was delays in pre-hospital care. The system was overwhelmed outside the hospital. And then the same thing happened at the hospital. But you also see this drop in places where COVID-19 wasn't as significant. And I think a lot of this has to do with the fact that patients just became more hesitant to go to the hospital because they were potentially afraid of getting infected with the coronavirus. And I think this is where there is room for better education of the patients. This drop was more dramatically in the milder stroke forms and TIAs, but it happened even with the large vessel occlusion strokes, and the pre-hospital system suffer in terms of stroke onset to hospital arrival as well.
You've mentioned also a drop in mechanical thrombectomy, intravenous thrombolysis. These are quite worrying. I mean, surely we would be expecting to see some long-term effects of not having these procedures done, not having stroke admitted on time. What do you think we will see in the longer term?
So we got a little bit of more granular detail in a US cohort. And here what we had is we had approximately 2,500 patients that were treated during the pandemic, and you compare with approximately 4,000 patients that were treated pre-pandemic. And then in US, we noticed almost a 40% drop in the amount of acute ischemic stroke hospitalizations, which correlate with a drop in intravenous TPA by about 30% and a drop in mechanical thrombectomy of about 24%. And this actually, when you look at the outcomes of the acute ischemic stroke pandemic versus pre-pandemic, we could quantify actually a 41% increase in inpatient mortality in relation to stroke. So I believe care has been compromised, not only due to a delay in a decrease in reperfusion treatment. There is also an effect, as I said, that the milder strokes were not admitted to the hospital, so that obviously will elevated mortality as well. But I think the quality of the care was potentially compromised. On the good side, the hospitalization length for both stroke and you're looking at acute myocardial infarction as well, the length of hospitalization dropped by close to 20%, and the hospitalization cost dropped by about 10 to 15%.
And I know that we've also heard from other studies that we are seeing more younger people developing strokes with COVID-19. Can you comment on that for us?
Yeah, sure. We did look at that at one of our analyses, and specifically was an analysis of this US data where, again, we compared over 4,000 patients in the pre-pandemic with 2,500 patients in the pandemic period. And there was a strong trend towards younger patients being admitted during the pandemic period. This has also been corroborated by some other single centers and even multi-center data set. It might reflect two things, right? One is, first of all, this category of younger patients without stroke risk factors that are now infected by COVID-19 and have strokes. I personally think that's a very small amount of the impact because this is still a rare phenomenon. I think most of the time when you have COVID-19 and stroke, you are just looking at an overlap of two common conditions. More rarely, someone who wouldn't have a stroke ends up having a stroke as a direct effect of COVID-19. And obviously, that's mostly the younger patient who wouldn't have a stroke otherwise. But the other fact that may have happened is the older patients that are theoretically more vulnerable to the more severe forms of COVID-19, there may have been a greater hesitation from their part to seek for stroke care during this period as well.
Sure. And finally, my last question. We are seeing a surge of COVID-19 in many parts of the world right now. What are your key messages or recommendations to stroke physicians around the world in preparing the service?
I think the key point here is we have to reach out to the population, and you have to explain to them that stroke is a very severe and time-sensitive disease, and there should be no hesitation in coming to the hospital if you have a stroke. We are prepared to safely care for them in the hospital environment despite the pandemic. And I would say that most of the time, stroke is going to be a more disabling and severe disease than the COVID-19 itself. And I think reaching out to the public and educating them about the need to come to the hospital is probably the best thing that you can do for our patients.
Thank you very much, Raul, for the interview.
My pleasure. Thank you for the opportunity again.